Hello and welcome fellow health professionals and students to our Lunch and Learn presentation brought to you by myself, John Kilpatrick, along with Bethany Devon, Ebony Cooper-Roberts and Matilda Bowman. Today's topic will take a look at drowning among those most vulnerable in our community. Drowning continues to be one of the leading causes of death in children under 4 years of age. In 2018 to 2019, Royal Lifesaving Australia reported 19 deaths by drowning in this age group, a 12% increase on the previous year. This presentation will discuss the anatomical and physiological differences in children under 4 years of age, along with the unique considerations which must be considered when providing care. Topics of discussion will include physical examination, health history, communication styles, cognitive development, and pain assessment. Relevant information regarding the age group's leading cause of injury, drowning, will also be included. There are pronounced anatomical and physiological differences between children and adults. Therefore, appropriate care and assessment styles relevant to age group must be provided. Some of the major anatomical differences for children aged 1 through 3 years include a small, flexible trachea and large tongue, which can easily result in an airway obstruction. The trachea is also short and narrow, which makes them susceptible to obstruction from foreign bodies, including water. The respiratory rate is much higher in small children as they require higher oxygen needs for their increased metabolic function, along with limited lung volume. Toddlers have a large body surface area for their weight, making them particularly prone to hypothermia when exposed to water or the elements. The head is also large in comparison to their body, making them top-heavy and liable to fall, causing injury. Their muscles also lack strength and coordination, further hindering their ability to maintain balance or swim. Soft bones break easily and offer little protection to vital organs, increasing the risk of trauma in young children. Unlike adults, cardiac output is reliant on heart rate rather than stroke volume in this age group. Therefore, heart rate is rapid when compared to adults. These are the normal ranges one should expect to see in children aged 1 through 4. As you can see, they differ quite considerably in comparison to adult parameters, with higher respirations and heart rate and lower systolic blood pressure. Pediatric patients have an exceptional ability to compensate during injury or illness, which can lead to the severity of their condition being overlooked. However, when these compensatory measures do fail, it happens rapidly and often irreversibly, leading to tragedy. As stated previously, children manipulate their cardiac output through heart rate and have limited control over stroke volume. When a child becomes hypovolemic, persistent tachycardia ensues, usually at a rate greater than 130 beats per minute. Respirations also increase to improve oxygenation, while peripheral vascular constriction is initiated to provide adequate perfusion to the heart, brain, and lungs for as long as possible. When these compensatory measures are exhausted, blood pressure will drop, leading to organ failure through hypoxemia.
There are several important components of a health history assessment. These include biographical data, past medical history including birth and neonatal history, nutritional assessment, functional assessment, social history, growth and development, and history of the presenting illness. When conducting a physical assessment on a toddler, there are several assessments used. These include the pediatric assessment triangle, physiological measurements, the anthropometric measurement, and a head-to-toe examination. All of these assessments provide critical data on a child's overall health and enables nurses to examine and understand the overall health status of a child. Pediatric nursing is based on the philosophy of family-centered care, which recognizes the family as the constant in a child's life. Nursing cares must support, respect, encourage, and enhance the strength and competence of the family by developing a partnership with the parents and family. A nurse can minimize negative effects and anxiety for all family members by building a therapeutic relationship, incorporating them into nursing cares, and including them in all aspects of decision-making and care plan development. When conducting a health assessment on children between 1 to 3 years of age, it is important to incorporate family-centered care to build a therapeutic relationship, which in effect allows appropriate information to be collected with minimal distress to the family. When conducting a health history assessment, a nurse must consider Appropriate setting by maintaining privacy and comfortability of both the patient and the patient's parents. Therapeutic communication by introducing yourself appropriately. Encourage the child to participate in the health history by incorporating play and using nonverbal communication such as hand gestures and facial expressions. Encourage parents to express any concerns or comments and ensure that these are addressed. Maintain direct focus with the use of broad, open-ended questions with guiding statements. Maintain cultural awareness and ensure care plan reflects personal preference of the patient and the patient's family. Show empathy and compassion. Gain trust from both the patient and the patient's family. Remain self-aware of both verbal and nonverbal communication. Toddlers range from 1 to 3 years old. Depending on the developmental stage that the child is at, their vocabulary may be limited and therefore the use of body language and hand gestures are an important concept of communication. Toddlers communicate with a combination of gestures and grunts, 1 and 2 word sentences, positive and negative emotional expressions, and body movements. Recognize these signs and encourage the toddler's efforts at communication. Respond quickly and predictably to toddlers' communication efforts. You're pointing at your arm. Is your arm sore? Expand on the toddler's 1 and 2 word communications and build sentences around their words. For example, ouch. Yes, ouch, that's right, your arm is ouchy. Ask parents about the child's vocabulary and how they communicate with others. This will give you more of an understanding on how you can effectively communicate with them. Use nonverbal communication such as facial expressions and hand gestures to engage and build a trusting relationship with the child. Play has long been regarded as a vital element in the normal growth and development of children and is widely used in many Western countries to alleviate the stress experienced by pediatric patients and their families during hospitalization. Through play, children can give the opportunity to develop mastery of self and the environment and to enhance their understanding of the world. Here are some examples of how play can be incorporated into all aspects of pediatric nursing. Preparation play, used to increase a child's understanding of physical examination and provide a sense of control over threatening events to help. Medical play, to facilitate children's expressions of their concerns and feelings related to hospitalization. This can be used to familiarize children with the hospital environments and routine. As a nurse, you can provide various real and/or toy medical equipment such as a stethoscope, syringe without needles, bandages, gloves, mask, and dressing packs. Get children involved in different kinds of expressive play activities and encourage them to share or express their feelings. This can include painting, singing, dancing, and sand play. Distraction play, to reduce the anxiety of children undergoing medical procedures. As a nurse, you can provide interesting games and toys such as bubbles, pop-up books, puppets, music, sensory toys, etc. This will distract the children's attention from medical procedures.
Jean Piaget invented the cognitive developmental stages in 1936. He devised 4 stages, which are sensory motor, pre-operational, concrete operational, and formal operational. Stage 1, the sensory motor stage, begins at birth to the age of 2 years. This stage incorporates the ability in developing an understanding of the world through movements and sensations, such as sight, sound, smell, taste, and hearing. As the infants and toddlers interact with their environments, they are continually making new discoveries about how the world works. This is a period of dramatic growth and learning for them. Piaget believed the most important development in this stage was object permanence, where the child was able to learn that objects exist despite not being able to see them. From 12 to 24 months, this stage of cognitive development ultimately influences the child's behaviorism, as curiosity is stimulated through physical experiences of everyday objects. These physical interactions additionally influence their ability to experience simple emotions, which equates to primitive kinds of affection, jealousy, sympathy, and anxiety. Decision-making abilities is limited, however they act on their drive for what sparks enjoyment. Stage 2, the pre-operational stage, begins at 2 years until 7 years of age. During this period, the child is not using cognitive operations, nor can they conjure logical ideas. However, there is a slight enhancement of language and thinking, especially in the early phases of 2 to 3 years. Piaget believed emergence of language is the major hallmark for this stage. The child's development consists of building experiences about the world through adaptation and thinking symbolically to represent objects. Additionally, toddlers have egocentric thoughts and communication, meaning the child is unable to see others' points of views. The early phases for this stage for children 2 to 3 years of age influences their behaviorisms and decision-making abilities, as symbolic representations are predominantly used where the child uses objects for different purposes. The child's imagination, playing, and pretending increases. As toddlers in this stage are egocentric, they lack the ability to understand that things can be different for others. This makes their behaviors more individualized to their needs and wants, not others. By 2 to 3 years, they are able to slightly understand conversations, and their decision-making abilities are based on thinking of satisfying their own desires. Children aged 2 to 4 years can only decide between two choices at most. For example, would you like milk or a juice? To conduct an appropriate and timely assessment of pain, the fifth vital sign, on an age range of 1 to 3 years, it is important for the nurses or other allied healthcare professionals to use the QUEST acronym. Start by questioning the child. Act appropriately to the child's cognitive developmental abilities, such as incorporating the use of their languages like saw, ouch, and hurt, and consider using a toy or other visual aid as a medium. Question in the same format as the PQRST acronym as you would an adult. However, simplify the question so the child can understand fully. When does it hurt? What makes it worse? And what makes it better? Use a pain rating scale that is the most age appropriate. For the age group of 1 to 3 years, there are 2 pain tools that can be used. The FLAC acronym, which is Face, Legs, Activity, Cry, and Consolability, is a behavioral pain assessment tool used from 2 months to 8 years of age. Each category is scored on a 0 to 2 scale, which results in a total pain score between 0 to 10, 10 being the highest level of pain possible. You must observe the child, then score each category as per the description. The Wong-Baker Face Pain Scale is normally used from the age of 3 years and older, and is the gold standard pain assessment tool as the child self-reports their level of pain. To appropriately use this tool, you must first describe the pain level and face interpretation to the child. Then you can ask the child to choose a face that best describes how they're feeling. Evaluate the behavior and physiological changes. Look at age-related behavioral changes in the child. Is the child crying? Is there muscle rigidity? Loss of appetite, change in sleeping patterns, increased heart rate or blood pressure? Are they sweating or pila? Secure parental involvement. Listen to the child's parents. They know their child best and they know what works to comfort them. Include them in decision making. Take action and evaluate results. After the assessment, identify appropriate pain relieving interventions such as administering analgesia and utilizing other comfortable measures. Then implement those interventions and review them within a short period, such as at the expected peak of the drug. Evaluate the effectiveness of the interventions and take action if the analgesia is ineffective. This ensures the assessment is valid and appropriate for the child. Remember, a good pain assessment is key to effective pain management.
There are many factors as to why children aged 1 to 3 years are at the highest risk of drowning. Children in this age group are very curious and mobile and are naturally drawn to water. In addition, they do not yet understand the dangers of water and have little ability to care for themselves. This relates to their cognitive ability, as discussed by Ebony. Physiological risk factors include children in this age group having underdeveloped balance and coordination systems. They also have a higher centre of gravity, making them more likely to accidentally fall over and into water. In addition, children under 1 are unable to perform the necessary and complex movements of swimming, such as breathing. A combination of these factors results in children aged 1 to 3 years being at the highest risk of drowning.
Risk factors of drowning include children gaining unintended access into swimming pool areas. This includes the absence of pool barriers, gates being left open, gates not self-closing and self-locking, and children using objects to breach barriers that are in place. In 2018, faulty gate mechanisms were the most common reason for young children unintentionally accessing a swimming pool. Ensuring a secure enclosure around pool areas is essential. Between July 2017 and June 2018, swimming pools were the leading location of death for children aged 0 to 4 years. All swimming pools must have a well-maintained fence or barrier that abides by local laws and building codes. If it is damaged, it must be repaired immediately. The owner of the land that the pool is on has a responsibility to ensure the pool fence and gate is well maintained and compliant with current regulations. Distraction resulting in a lapse of supervision is a contributing factor for drowning in children. Examples of this include checking on a pot in the kitchen whilst a baby is bathing, or adults talking and socialising whilst children swim in a pool. Adults multitasking can also be an additional risk factor. This may include watching children from inside whilst cooking lunch, or reading and glancing at children from time to time. Children can drown in as little as 30 seconds and in 5 centimetres of water. This can often happen in complete silence, and detrimental outcomes can take seconds to minutes to occur. In 2018, all children who drowned, there was an absence of adult supervision. Supervision is a key strategy to prevent drowning deaths in children. There are 4 elements of supervision, and they include proximity, continuity, focused attention, and preparedness. This means supervision must be consistent, uninterrupted, visual contact without any distractions. The most effective method of supervision is touch supervision. This is where an adult is always within arm's reach whilst a child swims to ensure their safety. In summary, we have explained how children between the ages of 1 and 3 have important anatomical, physiological, and cognitive characteristics that increase their risk of drowning. These include high natural curiosity, mobility, reduced physical strength and coordination, and limited ability to understand or make judgments about risk. These differences also affect the approach to clinical assessments. We have demonstrated how to appropriately conduct a health history and physical examination of children in this age group, taking into account the differences in vital signs, developmental stages, and communication styles of young children. Finally, we discussed important risk factors for drowning in this age group and strategies to reduce these risks, including appropriate pool fencing with self-closing gates and continual supervision within arm's reach of the child. Thank you for listening, and we hope you have learnt something from this session.